was a couple of years ago, of course, that we had a live event last with Giant, and we're back here, so that's great. Really good to see a nice full room as well, hoping that we can have lots of questions and interaction. We have an online audience who are now hopefully connected to this stream, so hopefully we'll get some connection from them as well, and questions I'm sure will be forthcoming. So without further ado, I'm going to introduce today's second session, and that is around how the AHSN, the Academic Health Science Network, can support innovators to demonstrate impact in the real world. And I'm going to introduce to you Elias Zapatas to run this session. Thank you, Elias.
Thank you so much. So hello, everyone. My name is Elias Zapatas. I'm the Deputy Head for Commercial Innovation at UCL Partners, responsible for real-world validation and technology evaluation function at UCL Partners. I'm also the sustainability lead and member of the working group of equality, diversity, and inclusion of the AHSN network. So as you can see from the slide, the AHSN network is a network of networks covering the whole of the UK. There are 15 organizations connected with the systems in place locally, trying to understand needs and priorities, and then relay them back to innovators to resolve these issues. So we are the catalyst of change. We are trying to connect partners to find the appropriate innovation to bring to the clinical practice. And we try to create the right conditions so that the innovation can generate the evidence needed to be spread and scaled up. And also we work and collaborate not only locally, but also nationally and internationally now with companies coming from abroad, trying to penetrate inside the clinical market and trying to generate the evidence in the real world. So we are here to discuss about real-world evidence. So what is real-world evidence? Real-world evidence is evidence generated in a non-controlled dynamic environment like the NHS, where many things can happen without prior knowledge. So we are trying to understand the barriers and enablers that allow this innovation to take place and also scale up and spread. We try to work with organizations in the clinical setting and generate evidence around health economics and barriers to implementation. And real-world evidence actually highlights further the value proposition of the technology, understanding the challenges that are happening in the local context. So at UCL Partners, we see actually real-world evidence generation as different pieces of the puzzle that come together to show you the fuller picture, the full impact that the innovation can have, and actually trying to generate those different tiles, as you can see here. You can have a better understanding and actually have a more informative conversation with the system. And I would like to invite on the stand Angela Garcia from sievert. So UCL Partners and sievert and the Northeast North Cumbria AHSN, we work together at a project to evaluate and generate real-world evidence of the Casper system. So the Casper system aims to digitize the referral pathway for endoscopy and trying to move from the paper-based traditional system to a system that we have increased efficiencies and supports patient and staff in doing their work. So Angela, please come forward.
Morning, everyone. Let's see. Right. So I'm here to talk about a pilot study from our experience implementing the electronic referral system for a endoscopy department at West Hertfordshire NHS Trust. And here I'll be talking about just our experience, and also how we use real-world data and how we evaluated the implementation early on, and also our early experiences working with AHSN. What did I do? Right. So this image basically shows you the complexity of making a referral for an endoscopy department at WHHT endoscopy department. As you can see, it's very complex. There's many steps involved. So, for example, if you are going into your GP and you need a referral for an endoscopy procedure, your GP would have to complete a paper form in different colors based on the treatment that you need. That doctor would have to write it manually, send it to the endoscopy department for processing and analyzing and determining whether it's an appropriate referral. And then once that was vetted and it's appropriate, then it'll be given to the booking staff to book your appointment. And so, as you can see in this image, it's very cumbersome. It's very complex. There's many ways that delays can happen, a lot of human error that could occur. And so that was the issue that WHHT wanted to solve, was to figure out a way how to improve this. And the way they wanted to improve it was to digitize the whole process. The reason why they came to sievert is because sievert already had a system, an electronic referral system called Casper, being used by radiotherapy and chemotherapy units across the UK. It reached about over 140,000 patients. And so they wanted to also use that software, that system, into their process. Also, our Casper system was flexible enough to meet the needs of the department. So that was the project that they wanted to pursue. In hindsight, though, there are a lot of resources and support that they needed to get this project going. And so we approached our local AHSNs. So WHHT approached UCL partners, and we approached our Northeast and North Cumbria AHSN to basically get more support in doing this project. Luckily, they said yes. And so this partnership between different entities formed. And so the project, again, as Elias was saying, was they basically wanted to digitize the way they make referrals, vet referrals, and book the appointments. The overall aim was to develop a system, an electronic referral system. The objectives was to create the software or the electronic referral system based on what the department needed, implement the system, and also evaluate. And so, sorry. So the first step in terms of developing the system, the way we did it was we worked with the consultants, figured out what the departments needed, and then reconfigure our Casper system to make it a Casper endoscopy software for their department. The next step was to implement the system. And so the way we implemented was we basically let it run for 2 sites, Watson General Hospital and Hemel Hospital. And so we let that run. The project manager visited and talked to the staff who were doing it. And it was more of an iterative approach because we really wanted to see whether the original design was fine. Was there any changes that needed, additions, or if it's a total fail? Luckily, it wasn't a total fail because it's been implemented for a couple of months now. And so this is where we started thinking about doing an evaluation. So the software has been implemented for a couple of months now, but we decided to do an early evaluation to figure out exactly how has it changed the pathway, the referral pathway and the vetting pathway and the booking pathway, how the software has changed that, what is the difference in quality of the referrals, and also just the satisfaction of the staff members using it. And so these are our early findings during the evaluation. As you can see, so I did the evaluation, and part of the evaluation was, again, trying to understand how the system has changed the workflow or the pathway of doing the referral system. And what we've noticed is that the pathway has really removed a lot of the cumbersome activities that could have produced a lot of delays and human errors based on just not having the doctors write the referral system by hand, or not having to transport the referrals to another department. So a lot of that was actually really removed by digitizing the whole process. And so we just wanted to show you how different the work path is when you digitize the referral system. So just a bit of lessons learned that we've learned throughout the process, and it's a lot longer. I just chose the top 5, but the first one is implementation is complex. So I've done a lot of implementation in public health. My background's in public health, and so I've implemented interventions, programs, and now digital health interventions in NHS. And whether you're implementing in NHS or a school or anywhere, it's very complex. There's so many unknowns that will pop up. And so you just have to roll with the punches. The other issue is that we had to embed this during the time that the paper-based approach is still being used. So we couldn't eliminate the paper-based approach entirely when we introduced this system. Second one is complex problem require complex solutions. So as I mentioned, making a referral, vetting the referral, and booking a referral is very complex. You may not think it is, but there's so many different steps. And so that require a very complex system. The third one is regular engagement with the stakeholders. So implementing any type of intervention is a very human-centric activity. And so it's really important for you to continually engage your range of stakeholders. So not just the clinicians, but also administrators or any other staff members who are part of or who are using that system needs to be engaged with it. And so having a robust way to maintain communication is important. The fourth one is evaluation provides insights and inform next steps. So evaluation, again, is really important because we've realized how our software has changed, or how our electronic referral system has changed the work path or the pathway. And I just wanted to point out, since we're talking about real world data, 3 and 4 is really the areas where we were able to generate a lot of real world data to inform our development of the software, but also how we implement it. So it's really important to have that access and to use that data to continually improve the system and the way it's implemented. And last is partnering with AHSNs enabled access to resources, support, and collaboration. So at least from my experience, AHSNs has really helped us identify how do we tell the story of our experience? What type of data is useful to tell the other people, the other NHS trust, that what we're doing is useful and valuable. And also, they help us do the evaluation. They gave us some recommendations on how to evaluate things. And so it's really been useful to have AHSN as a partner with this project. And lastly, just a quick talk about our next step. This is an ongoing thing. So the first thing is we're going to continue working with our site to improve the Casper system and make sure that we meet their needs. Again, it's very complex, so there's a lot of iterative changes in that process, which is also number 2, ongoing refinement and evaluation to Casper. So while we have done an evaluation so far, we're going to continue another one because we need to figure out financially how has it been advantageous to have this. Identify other sites that could benefit this. So you could imagine other departments across the UK do need to digitize the referral system. And so that would be an opportunity for us to partner with other sites. And lastly, continue working with AHSN, because again, they have a wide network of collaborators and partners. And we definitely want to use that to our benefits to tell our story. And so one of the things that we really want to do with our evaluation is to do a case study to tell our story about the electronic referral system and how we embedded it into WHT site. Okay, thank you. So if you have any other questions, my contact is here, and have a good day. Thanks.
Thank you so much, Angelo. It was really pleasant to understand and hear about the technology of sievert and understand actually the importance of real-world evidence, that they highlight further the complexities of the system, but also how important is the engagement with the local systems to be able to drive through innovation. And on this topic, we are going to have now on stage Nigel Harris and virtually also Louise Morper, CEO of Braininhand. They are going to be discussing about 2 SBRI projects they had and how these could lead to benefits out of this project. So Nigel, you can come on the stage, please.
Thanks very much, Elias. So we're based in Bristol. I head up the team that works with innovators to help them develop evidence and pull through their product or service into practice. We've got programs running around keeping people well at home, supporting young people with mental health problems, and also a new one on domiciliary care. But this morning, we're going to talk to Louise. Hi, Louise. Great to see you. How are you doing?
Hi there. I'm good.
Great. So, Braininhand is a really interesting name for a product. Can you tell us a little bit more about it?
Sure. So there are thousands of autistic people, neurodiverse people, people living with anxiety-based mental health difficulties who fail to reach their potential. So they might be unable to work, unable to go to college, unable to live independently. And this translates into very poor health outcomes, reduced life expectancy, high risk of suicide, high rates of unemployment. So we have developed a simple solution to help people live more independently. And we've got a pretty audacious aim. We want to transform lives, but we also want to transform the way that support is provided. So what we've developed is a combination of simple digital tools and practical human support, which is all about fostering skills in self-management. So if I was to use a fancy description, I would say we're a digital hybrid. But if I was to think of a more lay description, I think of us as a companion that's available 24/7 whenever someone needs us, designed around the user.
Right, that's great, thank you. So if it's available 24/7, then users are really going to be reliant on the app, and it's going to be a real essential support for them, isn't it? So it need to be 100% reliable. So that must have put some quite high demands, both on the development team and you in terms of evidencing reliability and effectiveness.
Yeah, absolutely. We've invested very heavily in our product and development team. When we started developing the product, the first place we looked was to the published evidence so that we could be confident that we understood what principles we were drawing, for example, from cognitive behavioral therapy, solution-focused therapy, other literature that shows how technology helps people who are neurodiverse. So that was our starting place. We wanted a product that was safe, that delivers good outcomes, that's value for money. So we're looking all the time to the evidence so that we can provide that to the people who use and purchase our system. Key to our development has been having a really strong logic model at the heart of what we do. So we're really clear about the activities that we're facilitating and how they contribute to good outcomes. And to start with, we were generating basic kind of case study evidence so that we could understand whether we were effective and whether we were reliable. And then we moved on to looking at self-reported outcomes from our users. For example, we need to understand, are our users feeling more confident about using public transport? Have they had an improved quality of life because they've been able to now get into and stay in work? And so we've moved on then from having case study, well, we've got user case study evidence, but we've also got case study evidence for our clients because we work in a public sector environment. We're working with local authorities and NHS organisations. So it's important to provide case study evidence of how we deliver value for them. So we absolutely have to understand not only user outcomes, but potential cost savings and efficiencies. And that then naturally takes us on to making sure that we have independent evidence, because we're obviously going to say that what we do is effective because we're talking to our users all the time. But we are reliant on getting good quality independent evidence. Would it be useful just to say a little bit about that, or do you want me to stop there, Nigel? I can't see you because on my screen your face is blocked out.
Oh, I see. Right. Okay. That's a shame. All right. So just talk a little bit more. You're still collecting evidence, aren't you, around effectiveness?
Absolutely.
So what sort of data are you collecting, and why are you still collecting data?
Sure. Well, when we started, we had some small independent studies. So we worked with the Holistic Society, with Devon Partnership Trust, which is a local NHS trust. And that gave us our early evidence around impact. More recently, we were fortunate to receive funding from the SBRI. We had phase 1 and phase 2 funding, which has enabled us to undertake a much larger independent study. And that's hopefully going to generate good evidence of impact and value for money. So that's in train. It's been, as everything has, affected by COVID and delayed somewhat, but we're getting there. But we don't see sort of collecting evidence as a one-off thing that you stop doing. We're constantly collecting evidence on how our users interact with our system, what the outcomes are telling us, what the cost savings are looking like. So it's certainly not just a one-off, get the evidence and stop.
Thank you. Now, how important do you think it is that evaluations are carried out independently? Because that must be a bit scary for you as a company, because obviously you don't necessarily know how the evaluation is going to turn out, do you?
Well, obviously, I mean, it's essential that we gather independent evidence, obviously, because you know, we need to know that what we're doing is safe and works. I think it is really challenging in quite a lot of different ways, and I'm sure members of the audience have experienced this themselves. So first of all, it's costly. So being able to actually either raise funds through grants or use investment funding to pay for independent research. I think the second thing is the methodology is really challenging. We're in an unusual space. I mean, a hybrid digital solution is quite novel in the mental health space. I'm not sure that standard methodologies like randomized control trials are really appropriate for a technology that's kind of constantly evolving and improving. Being able to actually get the right design for an independent research study, even for example, for our user cohort, neurodiverse users, there aren't very many standardized outcome measures that are suitable or that have been tested with our user population. So are we going to be able to find an independent evaluator that has that level of expertise, who can do a robust evaluation? And I hate to say it, but pace is also an issue. In the private sector, we do need to move quickly, and a lot of independent evaluation is undertaken by academics who tend to move on a different timescale and have different drivers. So yes, independent evaluation is vital, but there are many challenges that we're still wrestling with as we embrace independent evaluation.
Yeah, thanks. So I just wanted to pick up a little bit within that. You mentioned the logic model and the challenge of finding outcome measures. And so did you have a dialogue with the evaluation partner around, you know, what the most appropriate measures were and sort of mutually agree what those outcomes might be?
Yeah, I mean, my background is in research, so that sort of has helped me to be able to have robust conversations with our evaluation partners. So I was able to develop the original logic model and then share it and have it scrutinized by our evaluation partners, and equally to be very robust about whether or not I thought the outcome measures that were being proposed were suitable. But it has been not in negotiation, but we have had quite a lively back and forth, because as you will know, if you get the outcome measure wrong, you may well get a false positive or a false negative. So we want to be confident that the right outcome measures are being selected.
Thank you. You mentioned that you supply both NHS and local authority customers. Do you find that they place a different emphasis on different types of evidence?
Historically, I would have said that local authorities seem to be more interested in sort of video case studies, qualitative findings, but that's really shifting. And I'd say both NHS and local authorities absolutely need robust evidence about efficiencies and savings, and are probably expecting more independent evaluation. I still think the conversations we would have with NHS organisations will move more quickly to things like the NICE digital evidence standards to understand what tier you're on. We're on tier 2, we're trying to get to tier 3. We're also finding, and this is more in NHS organisations, reference to the DTAC, the digital technology assessment criteria. We're finding that is something that commissioners are expecting us to be able to evidence compliance with as well. And that doesn't seem to yet have translated across to local authorities.
Yeah, I'm sure it will follow. Really good, thank you. So just one final question. Could you just say a little bit about how the AHSN network has helped you in this journey?
Yeah, I have to say, I know I would say this, but we've had huge help from the AHSN. So first of all, when we were thinking about applying for SBRI funding, we went to our AHSN partners and said, this is what we want to do. They facilitated introductions to practitioners, to researchers. When we put our application together, they reviewed it and gave feedback. They even set up a dummy panel for us so that we could do our presentation and have it sort of scrutinized and checked. So we've had really practical help from our AHSN partners, and then we've had lots of introductions to people who it might be useful to connect with. So yeah, I'm very grateful for all the support we've had from a number of the AHSNs across the country.
Thank you. That's really good to hear. So thanks so much for joining us this afternoon. Oh no, still this morning. So lovely, and look forward to seeing you again soon.
Thanks very much. It's been a pleasure.
Bye.
Thank you so much, Nigel and Louise. And as we can see from the first two presentations, innovative solutions that are proposed for challenges in the system, we can see that they need to be simple and practical in order to have traction within the clinical setting, not to over-engineer the solution there. And also the AHSNs help to develop the case study with robust evidence that can actually highlight the economic implications of implementing the solution, but also the efficiencies within the system. I would like now to introduce on the stage Andrew Walker from Health Innovation Network, and we'll have virtually with us Carey Mcclellan from Get You Better, where they're going to be discussing a self-management app for acute back and leg pain. So Andrew.
Thanks. I'm Andrew Walker. I head the evaluation team at the Health Innovation Network, which is the academic health science network for South London. And today I'm joined by Carey Mcclellan, who is the CEO and clinical director for Get You Better. And we're going to talk about the journey that Get You Better has been on around evidence generation, how Get You Better came to work with us in South London to use the Digital Health Technology Evidence Standards Framework, the NICE framework, to map their evidence base and identify kind of where gaps were and where they might, where we with them might think about improving and developing that evidence base. I'm going to hand over to Carey to sort of lead us in and talk about Get You Better and their journey up into the point where they started to work with us. So Carey, please shout out when you want the slides moved on.
Thank you, Andrew. I hope you can all hear me.
Can we just have the slide?
Thank you, Andrew. And well, I'm sorry I can't be with you all today in person. My name is Dr. Carey Mcclellan. I am a physiotherapist and an academic doctor. I also boundary span. I am a clinician, operate as a clinical director at Get You Better, but also have a research background. Now, musculoskeletal injuries and conditions have a huge impact on both patients, the NHS, and the workplace. They take up about 30% of all GP appointments in primary care. And there's a real need at the moment to support self-management and prevent over-treatment, which occurs in both physiotherapy, prescribing. And Get You Better provide a platform which provides digital self-management for all common musculoskeletal injuries and conditions across an integrated care system. Our platform is integrated into all parts of this system where patients make contact, GP practices, urgent care centres, physiotherapy. We work with the organisation to configure their musculoskeletal pathways for back pain, back and leg, neck, knee, shoulder, all common conditions to their local region, and then enable them to provide what is termed as a digitally enabled musculoskeletal pathway. We're a platform with a patient-focused app, and that's everything that we do, but what sits behind it is our platform and interoperability within the system. If you go on to the next slide, please, Andrew. So our aim at Get You Better is to provide true local self-management support to help patients trust their recovery and have the confidence to get better without overuse of healthcare resources. Crucially, we provide a whole pathway local approach to self-management. Now, what this includes is safety netting, day-by-day recovery for a condition such as knee pain, back pain, referral into the system when needed, rehabilitation when needed. When patients are better, we support prevention. And really importantly, at the moment, patients are waiting longer and longer for appointments, and we provide support on a waiting list and PIFU, which is patient-initiated follow-up. So our journey to this point, and we're currently being used in 6 integrated care systems, but our journey started a couple of years ago working with the West of England Academic Health Science Network with the SBRI Healthcare. If you go on to the next slide, please. We had a platform that could deliver back and leg pain, but that didn't meet the needs of the system. And so we did a feasibility study to produce integrated self-management and prevention for multiple conditions and pathways in the health service. And this was really a feasibility study of our technology in the real world. It enabled us to do quite a lot of co-design work, both with patients, clinicians, the CCGs, the commissioners, and also work to do a full economic impact of our technology on the NHS. And that was work with the Academic Health Science Network. What came out of that with our stakeholders was a phase 2 contract with the SBRI Healthcare. And for those of you that aren't aware of the SBRI Healthcare, it is an NHS England-led contract for companies to develop technology. And it's usually led by the Academic Health Science Networks. And what the phase 2 study did, it enabled us to do 4 things. Firstly, to develop the product from the feasibility, which we co-designed, and we knew would have an economic impact from our work with the West of England Academic Health Science Network. It enabled us to continue with already deployment across a CCG, a clinical commissioning group, into 40 GP practices. But crucially, it enabled us to work with Dr. Walker and the Academic Health Science Network to do an evaluation aligned to the NICE digital health technology framework. And we started off by doing a gap analysis. We then went on to do co-design work. We incorporated behavior change. We looked at real world data. We took and canvassed the opinions of patients and clinicians and the system, validating Get You Better, which ended up with Get You Better platform being on a case study on the NHSX digital playbooks. I'm going to hand over to Andrew now.
Thanks, Carey. Apologies for the slides jumping. I think there must be a timer. It's not that I'm trigger happy and jumping backwards and forwards. So apologies for that. So as Carey said, so what we wanted to do together was use the NICE evidence standards framework for digital health technology as a way to map out and validate what data Get You Better, evidence Get You Better already collected, as a way then to identify where their gaps might be in their evidence base, and then plan additional data collection or evidence generation. So I'm just going to briefly talk you through the NICE evidence standards framework in case you're not familiar with it. So I think Louise, in the previous presentation, sort of nicely segued to it in terms of it being a good place to start in terms of your evidence, sort of your journey around evidence generation. So it was originally developed in, I think, sort of 2018, actually 19 crossover, but was updated in 2021. The framework has 3 different tiers, which cover different sort of levels of functionality within digital health tech. And within that, there are different functional classifications. I'm going to not get too techie about it, but just to sort of give you a brief run through. So basically the bottom tier, tier A, is called system impact, and essentially that's system services. So that's tech that doesn't collect data or use data specifically from patients. So an example of that might be your award sister, you need a piece of tech that helps you get your roster sorted for your service for the following week. So that's an example of how you might think about tech at that level. Tier B is where the technology is being used to for the patient to understand their condition or as a means to communicate between the clinician and the patient. So an example might be that of video conferencing, or another example might be where data is being collected about the patient, but it's not being shared with the clinician. So it could be that they're using the app to track their own physical activity. It's for them to use, but that data isn't being shared more widely. The third tier is where there is some form of intervention. So there's actually some kind of activity within the app that is making some kind of recommendation to the user, so the clinician or sorry, the patient or the service user. So that could be linked to preventative behavior change, it could be linked to self-management, or it could be actually diagnosing or recommending treatment. Okay. So the first thing you do is when you're trying to think about this framework is to identify where the technology sits within this hierarchy. So what tier and what specific functional category does it sit within? And then basically you base your sort of mapping of evidence against that hierarchy. Okay. I think the important thing to note about this framework is that it's cumulative. So if you're sitting at the top, if your technology is a tier C technology, you have to meet all the criteria of evidence sitting below that from tier A, all the way up to tier C. It used to be tier 1 to 3, so I flip and flop between the two, apologies. It also has evidence or guidance about how you might approach doing some economic analysis linked to your particular tech as well. So thinking about the scale and scope of the tech and the potential economic impact that would have in terms of the scale of commissioning. So if there's local commissioning, the impact is quite low in terms of potential financial risk. So the needs around the evidence generation for the economic analysis is smaller. Whereas if you're looking at something that's got England-wide commissioning, then obviously you need a more robust evidence base in terms of the economic analysis. I think the key thing for the NICE frameworks is it helps you to understand what evidence you have. And I think importantly, it helps you understand what evidence you need in terms of thinking about you as the innovator, but also as the potential provider or commissioner who might want to use this technology. Oh, could we bring the slides up, please? Back button. It's back again. Thanks. So I'm going to talk about how we use the framework with Carey and Get You Better, specifically as part of the work we did with them. So as I said, we use the NICE framework to basically map the evidence that they currently had for their technology. This to the left is, well, to your right, sorry, is a more detailed breakdown of the various different subcategories of the framework. So the different areas that you're specifically looking evidence for. The framework describes for each of these criteria what the evidence looks like. And there are different types of standard, minimum or best practice, and you rank against that. So we did that. Carey and colleagues provide us with all the evidence they had. We did our mapping exercise, and we identified down at the bottom C that they had a gap around demonstrating effectiveness. So then following that, what we did was we worked with Carey, other colleagues in the system to co-design a mixed methods evaluation to try to plug some of those gaps. The caveat here is we tried to do that during COVID, so it was a bit of a challenge. So there are lots of constraints that we had around doing that. But specifically, the evaluation we developed were thinking about how we could show different aspects of demonstrating effectiveness. And the NICE standards are really clear about what that is in terms of what the different elements of demonstrating effectiveness look like and the different types of methods that you might use to do that before, after, controlled studies, etc., the different types of methods that you might use. So we specifically looked at effectiveness in terms of condition-related outcomes, behavior change-related outcomes, satisfaction, both in terms of the user, the patient, with the MSK condition, but also satisfaction from a clinical perspective. You know, what did the GPs who were referring this app to patients think about whether or not it was delivering benefit for their patients, whether or not they thought it was suitable for their particular patients. So that's a quick sort of whistle-stop tour through what we did. I'm just going to now hand over back to Carey to give you an update of sort of what the picture looks like in terms of the evidence base now for Get You Better and where they might go next.
Thank you, Andrew, very much. So following the end of the SBRI healthcare project in March, or well, actually it ended up being July this year, It enabled us as an organization, as a company, delivering digital health technology to move forwards on its evidence-based evaluation. So a certified medical device, we have a nice digital health technology evaluation at 3A. We can demonstrate behavior change of patients in our system. We have an economic evaluation that led into an ORCA app library, which is used currently as the NHS app library, a 91%, which is currently the highest scoring MSK app in the UK. And crucially, it also feeds into the digital technology assessment criteria. All of the above, including the NICE digital health technology evaluation, feeds into a sign-off for this criteria. And also the evaluation I work with Andrew enabled us to provide enough independent evaluation that we needed to be able to be supported and adopted by the NHS playbooks as a South West London case study nationally to reimagine, redesign pathways. Andrew, the next slide, if you could. Just very, very quickly, the kind of outcomes we were drawing from this were realizable benefits, really. Just back one, if you could. Back one, that's it. The realizable benefits that we were able to demonstrate to our customers, not the patients, to customers, were cost-benefit ratios, reduction in physiotherapy referrals, reduction in GP referrals, 50% reduction in prescriptions. We were able to say that we've asked the patients, we know from Andrew's report, from this evaluation, that it improves the confidence to self-manage, the ability to self-manage, and the understanding. And again, if you just go on to the next slide, it sounds like it's difficult. You've got some auto stuff going on there, Andrew. But if you go on to the next slide, what fed into this work, which I find really great, is that we were able to work with a university in a three-way kind of collaboration with Andrew and his team to incorporate behavior change assessment that we're doing independently with the academic health science network. What's next for us is a larger real-world evaluation of clinical effectiveness and a piece of work around digital inequality. So the next stage is a larger NIHR level type of academic research into clinical effectiveness. Thank you.
Great, thanks very much. We now need to move on, but if anyone wants to find out more about our work, both at the HIN, also with Carey, our contact details are up there. So thanks so much for your time.
Thank you so much, Andrew. Thank you so much, Carey. So, Andrew, I would like to welcome you back on stage. And with him, I would like to welcome also Sophie Young and Nigel Harris. And virtually, we will have Scott Cunningham. We are going to have a panel discussion now to deep dive a bit more about their advice around real-world evidence. So, Sophie, I would like to start with you. I would like to ask you to introduce yourself and also tell us more about the project around type 2 diabetes you're running, the risk stratification model, and how important is the real-world evidence generation?
Thank you. So my name's Sophie Young, and I'm one of the health research leads at Imperial College Health Partners. And we were involved in a collaborative project with MIWA Digital Health, AstraZeneca, ICHT, IGHI, and Northwest London CCGs, which aimed to revalidate risk prediction models to prevent complications in patients with type 2 diabetes, and then link those models to tools for patients and clinicians, and then independently evaluate those tools. So there are two key areas where real-world evidence was used. So ICHP hosts the Discover dataset, which is a linked coded primary care, secondary care, community, social care, and mental health dataset, which covers over 2.5 million Northwest London patients. And what we aimed to do was take some models that were developed up in Scotland by with MIWA Digital Health and revalidate those in the much more ethnically diverse Discover dataset. So we supported the data extraction, and also our Discover platform hosts an auto machine learning tool called Data Robot, which was used to help improve some of the model revalidation methodology as well. And then the second part in which we used real world evidence and the Discover data set was in terms of recruiting people for the evaluation, which was led by IGHI. So we host a consent to contact register, which includes patients in North West London who have consented to be contacted for research purposes and evaluations and projects such as this. And their information is linked into the Discover data set. So we've recruited patients from that register to be involved in the evaluation as well.
Thank you so much. Now we turn to Scott, who is online. I would like to ask you, Scott, the work that has been done with ICHP. How did this work actually, what were the challenges that you have identified doing this work, and how the work with ICHP aim to address those and move forward?
Hi there, and thanks for the opportunity to speak to you today. So I'm Scott Cunningham. I'm one of the co-founders of MIWA Digital Health. We're a spin-out from Dundee University, where we've been developing computer services for diabetes for the NHS for over 20 years. We primarily produce patient-facing services for records access for individuals and electronic medical records, where I was the technical lead for Sky Diabetes, which is the electronic medical record for diabetes in Scotland. And I was in that position for over 15 years. More recently, we've been focusing on AI-based risk prediction models, which is why we got involved with this project. Where we actually started our journey with the AI modelling was through an Innovate UK funded project through one of their digital health technology catalyst programs. And we used that project to develop a number of literature and AI-based risk prediction models based on the national data sets that we have available in Scotland. So moving on to the project that we did with North West London and funded through HDR UK and in collaboration with Sophie and colleagues, the project basically helped us to validate the models that we developed in Scotland with the much more ethnically diverse diabetes population that is available in North West London. Some of the challenges, well, I think most projects have problems with information governance, but fortunately we were able to navigate them pretty rapidly due to an existing IG framework that was in place, and we were able to adapt that to accommodate for the purposes of this project. Some of the good news that came out of it, the models performed very well in the environment with London data, which was really good to see. The feedback we received from both patients who were involved in the evaluation and the healthcare professionals, both on the display and the user experience, were all very positive. And we used that later on to help us to modify and adapt the service. There was a large number of suggestions that came out of the feedback from both the patients and the healthcare professionals that were involved, and these have all been factored in, reviewed, prioritised and factored into our development pipeline. And there were some tweaks that we made to the models, and it's basically helped us to modify and fine-tune the models that we developed in Scotland. So it's been a fantastic project to be involved with.
Thank you so much, Scott. So Nigel, now to you, and from your experience to date, I would like to ask you, what are the things that NHS is looking when conducting the real-world evidence?
Okay, thanks for that. Well, obviously, clinical benefits are sort of top of the list, and that's sort of a given, really. But then its cost benefit is still top of the list. So, and we're talking about cash releasing. So, you know, it's not just savings in staff time, which may be theoretical and, you know, may realistically not be realisable. Case studies are always useful. People love to hear a story, so I would always recommend a good case study. And then obviously, you know, the gold standard would be an at-scale independent evaluation would carry the most weight. Having said all that, we are, as we all know, living in very challenging times, and we've got major issues around elective capacity and workforce. And so we're very open to explore innovations that maybe not got such a strong evidence base, but can help with this, the challenges we're facing at the moment.
Thank you so much. So Andre, to you now. And just Nigel mentioned about the importance of conducting independent evaluation. So I would like to ask you, what is the one piece of advice that you would like to give to innovators trying to undertake independent evaluation and identifying the right partner there?
Sure. Can I be quick and give two top tips?
You may.
It's picking up on 2 points actually that Louise raised in her talk with Nigel, and I think it's about evaluation is really expensive and time consuming, so it's being really clear about the purpose of why you're collecting evidence, and clear about the aims and objectives of that. And I'd go back to the NICE evidence standards, map out where you are on your evidence journey to target specifically where the best use of that time and energy goes. So that's my first advice. And also it makes it easier from a commissioning perspective. If you're going to an independent evaluator, if you're really clear about what it is that you want to know, that's really important, because they can then come back with a clear kind of plan about the best way to approach that. The second part I would say is around choosing who is the right evaluation partner based on the type of evidence that you're trying to collect. Typically maybe two buckets. You've got people who are sitting in academic settings doing research, whereas you might have people who are research agencies, maybe AHSNs perhaps, who are more in the pragmatic evaluation side, and the pros and cons on both sides. Research, really high quality, really rigorous evidence generation, but the issue there is that the timelines for doing academic research are quite long, and academics often have different, they want different things out of it perhaps. They're looking for peer review publications as a key output, because that's what they're often kind of measured against. Whereas for an AHSN, it's more pragmatic. You might, or another type of evaluation or research agency, they can turn around the evaluation perhaps in a shorter time scale, and maybe more responsive, but will be doing more pragmatic evaluation rather than research. So you need to kind of think about kind of what you're looking for.
Thank you so much. And before we close, I would like to open the floor to questions. And before doing actually that, I would like to ask how many of here from the audience have already undertaken a real world evidence or are considering. So you can raise the hands. So actually, the lady in the audience, I would like to ask, what were the challenges so far in undertaking the real world evidence?
I mean, to be fair, I'm not really sure where to start. It's been a incredibly challenging process. I think one of the biggest parts has definitely been around getting that first early adopter. Without obviously the existing evidence, it's really hard to encourage and get across the real benefits that we know that we can provide. But getting someone, particularly a customer base as the NHS, where they're even more careful with the funds that they have, they're constantly firefighting, they don't have the luxury like the private sector does to be able to think more long term. So to get someone, first of all, to just agree to be an early adopter and just to try it and see what happens, that's definitely been the biggest challenge. And then it's also around just the implementation. The teams are so busy, they've got so much other challenges themselves within the workforce. So to build a strong enough team to actually get the implementation going fast enough, that's been an incredibly big challenge that we've had to deal with. And just the data points as well, like as you've touched upon, these different evidence points can be really difficult because data across the NHS is so disjointed. So to actually get strong data out the back of it, you almost need good baseline data to start with. And that is a huge challenge to actually get. So yeah, it's been a fun journey.
Thank you so much, and apologies for taking you by surprise. So I would like to ask now the panel to reflect on what they have heard and what advice that you would like to give back to innovators that actually are going through these kind of hurdles. Anyone?
I suppose I picked up the mic first. I set myself up tonight. I think your experience is really normal and reflects a lot of innovators, SMEs experience. And so even though that might be slightly disheartening, it's also sort of reassuring that you're kind of you're not alone. This is normal. I think you're quite right. It's finding that first key partner. I think there is very little resource in the NHS and social care to implement additional funding. So you basically need to find a partner who wants to pull it into their service. So there's that kind of, that they're up for this, they're going to make the effort, they're going to realign resource to make this happen. And also that they want to work with you because they want to develop the evidence base too, not just for your tech, but from their perspective, how does this tech, or often they're thinking a tech like yours. So if later down the line they go out to re-procurement, they're thinking about it could be tech agnostic, but at least they know they've got a better idea of what they might then go out to commission later when they've got some kind of evidence base. Yeah, and speak to your local AHSN, I guess.
Thank you so much. Oh, Nigel.
So my top tip would be find yourself a clinical champion. So find somebody on the inside who can work with you, understands the product, and will act as a gateway or a way into your local health system.
Thank you so much. And actually, I will come to Scott now, asking how did he overcome a similar challenge? How did he overcome trying to identify the early adopter and the side that actually they were willing to work with them?
We were quite fortunate that we had a sort of long-standing arrangement with the No Diabetes Service, which we've been delivering for North West London since 2017. So we had a good relationship with the team there within the diabetes network. So when it came to the point when we'd finished our evaluation of the service of the AI tools in Scotland, we had an interested party who were actually willing to work with us to evaluate further with, as I said, a much more diverse sort of demographic within that environment. So hence how we got involved with the project. NIHR, HDR UK had funding available at the time, and it came at an opportune moment for us to actually be able to apply for that. And since this project actually happened, we've since managed to get further funding for an AI award through NIHR. So all of this ongoing evaluation has been hugely beneficial.
Thank you so much, Scott. And we can see from all the presentations that funding was an important element in order to be able to progress those studies. So I would like to ask the panel, how do you go about identifying and securing the appropriate funding? Because as we know, it's a competitive landscape. It's not always easy to conduct a study around real-world validation.
I'll pick that up first quickly. So we have a Future Challenges program, and working with our local system, we identified a number of key priorities. So keeping people well and healthy at home, young people's mental health and resilience, and now the domiciliary care workforce challenge. And we specifically allocated funding to support the evaluation of those products and work with the innovators.
Thank you so much.
So another key point, I think, is kind of highlighting the strength of your partnerships. And for example, with the Radar Catalyst project, it's very much a cross-sector partnership and collaborative project. And I think that that's something that can be very much of benefit in terms of applying for funding as well.
Scott, do you want to add anything?
Yeah, I think, again...
So I was going to say, just coming from an academic background, we've had many years of experience writing proposals, and I think there's a lot of good opportunities out there through, as I mentioned, Innovate UK, NIHR, even SBRI, the Small Business Research Initiative. They do tend to have very themed and focused topics for innovative projects, and we're always very keen on picking off every single point that they're asking for as part of any proposal that we put in. So yeah, attention to detail is essential for these sorts of folks.
Thank you. And Andrew, I noticed that you picked up the microphone. So last few words.
Yeah, it was just really quickly. So there's a big pot, SBRI going to NIHR, which, is big scale, clinical research type studies. But there are local sort of funding sources as well. So in South London, we have every year what we call the innovation grant. So it's between £10,000 to £30,000 to partner with a local provider or commissioner to get your kind of pilot your innovation. We also have Digital Health London, which we're in partnership with the 3 London AHSNs, where you go onto a program. It's a competitive process, but then you have a whole package of support with navigators to help you make access to people in the system, different types of access to support around evidence generation, etc. So there are lots of different sort of avenues. So again, I'd probably say speak to your local AHSN who might be able to signpost.
Thank you so much. Thank you so much, the whole panel. And before closing, just to reiterate some key elements we heard today. So it is quite important to undertake your real-world validation to identify the right independent evaluator in order to support you in this journey. And then you need to decide what kind of evaluator are you looking. Are you looking for an academic evaluator? Are you looking to have a publication coming out of it? Or are you looking for a more pragmatic approach where you want to scale up and spread your adoption as fast as possible? We also looked about the solutions, innovative solutions. They need to be practical and simple to address the clinical and local needs. Sometimes we see those solutions to be a bit over-engineered there, and actually they create more challenges than the actual problem is. And it's quite important, actually, out of the real-world validation to create a case study that highlights the economic impact of your innovation. Nigel talked about cash release innovation. It's very important to differentiate what are the cash relation evidence there and what are the efficiencies in the system. Both are important, but sometimes we see innovators that they mix those up. It's quite also important to find your clinical champion within the system. They are those people who are going to be the driving force. They are going to link with the system, and they are going to make the network, the community of practice out of which that actually will support the development of the real world evidence study, but also the further scale up and support. And lately, it's very, very important to consider the workforce implications when we drop innovation in the clinical setting is not only in the interaction with the rest of the infrastructure, the interoperability that we usually hear, but also we need to understand the acceptance that the staff will have, the experience that they have, and how much acceptable they are. You may have people who are more open to innovation and others who are lagging slightly behind, but you need to make sure that you're taking the whole, everyone as part of your journey, and also always consider patients. Even though your innovation may not be patient facing, absolutely will have an impact on the patient. So always having the patient outcomes at the back of your mind, the clinical impact. So I would like to thank everyone being part of the panel today and the presentations. Thank you, the audience, for being here and the online audience. And before going, I would like to ask you, if you want to find more about the AHSN network, you can follow our online website, but also you can submit your innovation on the healthconnect.org.uk, where the AHSNs collectively discuss about your technology, and then it's allocated to individual AHSN depending on the expertise we have on the ground. So thank you so much for your time today. Thank you.
So thank you again to the panel. Fantastic, really informative, lots of information there. And like Elias says, you know, do get in touch with them via these contact details if you want to be involved in some of the stuff that's going on and access the funding, etc. Thanks, everyone. And we're going to be jumping straight onto the next session in just a moment. We're just going to drop the feed and come back again. So stay with us or change over. Thanks again to the panel.